He is a senior lecturer and former head of Department of Surgery at Cotalawela Defense University, Colombo. He is a former honorary consultant surgeon of Sri Jayawardenepura General Hospital in Colombo and the past president and honorary fellow of the College of Surgeons of Sri Lanka. He has been a resource person for more than 90 trauma courses for doctors in Sri Lanka, director for 44 trauma courses and 16 for nurses, as well as the training of trainer courses in trauma in Bangladesh and China. He is the global chair of the National Trauma Management Course and council member of the International Association of Trauma and Surgical Intensive Care or IATSIC. He is a member of the Global Alliance of Care of the Injured at WHO Geneva and has delivered more than 60 lectures in Sri Lanka and abroad on the subject of trauma. So, ladies and gentlemen, let us all welcome Dr. Ranjith Ellawala on trauma system in Sri Lanka and what more to be done.
Right. Sorry about that, actually. And so a size of 65,000 kilometers and 21 million population and commonest hospital admission and nearly 3,000 in-hospital injuries recorded and 10 costs of in-hospital deaths, nearly about 6 to 8 deaths from RT alone. And we enjoy a free health coverage. And most of the injured seeks medical attention in public sector. So you can imagine the financial burden to government from health, because as we have a very high injury rate. Let's talk about the prevention a little bit. We are not very good at prevention, and you can imagine, what we have been doing all this time, and to have this amount of injury burden. And I also asked myself actually what we have been doing and to do. And UN, the first decade actually, and the government got involved, and the Ministry of Health got involved, and there hasn't been much of success. Now they have entered the UN second decade of injury prevention for this decade. Now, there is a National Council for Road Safety, which has been developed by the Ministry of Transport. And Ministry of Health has another committee, Injury Prevention. And the Ministry of Health Committee for Injury Prevention is working closely with the National Council for Road Safety. And there is another agency being started that's covers not only road traffic accident, but also have covering the other areas of injuries as well. Now, a lot of people believe that there should be an apex body, and which is under the president or the prime minister, which is the one which is going to be effective in this country. It's very difficult to say at this stage actually what's going to be effective, because people have tried various ways of doing the injury prevention, but the outcome has not been all that successful. There are the individuals who are doing various activities, but collectively, it has not shown a lot of good outcome. The surgeons' involvement, that is through the various the committees involved, and we do actually help, and the Ministry of Health to get a very good prevention and if at all. Let me talk about the pre-hospital care. Now, in 2004, we started the first pre-hospital care project in Colombo, that is the capital, and with the group of 20 fire brigade recruits. And that worked for about 2 years. Then it stopped because there was no support from the government or the Ministry of Health. Now, 2016, and the Indian government donated this ambulance service, which developed over the period. Today, we have a fleet of about 300 ambulances covering the entire country with 1,400 paramedics working with them. And this has given a lot of, good transport of the patients to the centers, and without much problem. But during this period, COVID period, they are engaged in the transport in the COVID period. But I think this is a good service, and those people were trained in India and giving a very good service. But the small percentage in certain areas are still being transported by common private vehicles. In the places, remote areas, agriculture areas, they are transported by the tractors and trailers. And in the city area, sometimes they are being transported by three-wheelers, although that is not a very good way of transporting. I hope that in time to come, the network will improve, and there will be more the communication with the ambulance service and the receiving centers, and to improve the services. Talk about the institutional care. And most of the injured patients will be able to reach institution, receiving care within 2 hours. And there are so many smaller hospitals scattered around the country, and but the centers which gives the definitive care are a place where there is a surgeon and anesthetist. We have such 53 such institutions spread out the country. Now, this range from the teaching hospital, provincial hospital, and right down to the what is called base hospital, where there are at least 2 surgeons and 1 anesthetist. In addition to this network, there are 2 trauma centers. One is very old, attached to Colombo Hospital. Another one is a smaller one in the north of Colombo. And these centers have been their existence for the last 30, 40 years. And but they are catering only for the accidents only. But country is not developing any more accident services, because it's we have decided to have A&E departments throughout the countries, and there is that is a cabinet decision, and there are so many A&E departments are being newly developed, and those who are existing, we are upgrading. This is from a grant from the World Bank, and it is happening at the moment. So almost all the A&E departments are manned with medical officers. Only some of them are being supervised by the consultants. So general surgeons have the key, they are the key stakeholders, and they have the main responsibility for the injured. And we have nearly about 100 general surgeons scattered among those 53 institutions. And orthopedic surgeons are helping with the bone injuries, and nearly about 50 around the country. And we have an anesthetic cadre of about 150 to 170, and helping the general surgical colleagues and the orthopedic colleagues for the definitive care. Now we have plastic surgeons looking after the burns, and emergency physicians is a new specialty which has come during last 2 years. So we don't have emergency physicians covering all the A&E departments in the country yet. But in time to come, I think they are very fast developing specialty. Neurotrauma. All the neurotrauma is handled by the neurosurgeons. There are about 18 scattered around the country, but there is a large neurotrauma center in the Colombo, and with a dedicated neurotrauma ICU with about 15 neuro ICU beds, and also nearly 200 the ward beds for the neurotrauma center. What about the trauma ICU? Colombo has a dedicated trauma ICU with 10 beds with a trauma intensivist, and in all the other regions, this ICU is shared by the general ICU as well. And once again, the intensivist, consultant intensivist is our once again new specialty, and which is developing. Only few centers have intensivists, but otherwise the consultant anesthetists are supervising the ICUs as well as helping the trauma the systems. It's not uncommon to find burns in our country, and there is a specialized burns unit in Colombo, and a children's hospital in Colombo, and one provincial hospital. But otherwise, the plastic surgeons are looking after them, and they are caring in their plastic surgery wards. We have the radiology support. Most of the 53 institutions have general radiologists, and CT scans are available only in the provincial hospital, which comes to about 20 units. And we don't have angioembolization for continuous service. Only in the major centers we have angioembolization could be performed, but still not the good service. The MOs in the A&E departments are being trained in the fast scan. So what is this training about general surgery? Now we produce surgeons with a special interest. Now, general surgery with a special interest in trauma was started about 6 years ago, and not a lot of people are interested in doing general surgery with a special interest. Most likely reason which I can see is financial reason, and then there are a lot of surgical trainees who are in the system of being trained, and they are part of the treatment teams. And then the doctors, we have training the courses like NTMC, which was mentioned by Elmin earlier, and the ATLS. And as far as the College of Surgeons are concerned, NTMC has been there since 2009, and it's very popular course. And we, over the period, we have trained about 2,000 doctors, and in the time to come, we will be doing more and more frequent training for the doctors. Now, ethically, what we found that most of the doctors who are undergoing these trainings are the postgraduate, but we need to concentrate the training on the doctors who are manning the A&E departments. Now, NTMC has been a very the basic course, and which has been very popular, but the cost of that is very minimal for our country, and comes to about the US dollars 25 per person. And the nurses, for the nurses training, we have developed what is called initial trauma care for nurses in 2010, and the nurses are being trained in that as well. So we were looking at advanced trauma courses like DSTC, but unfortunately our culture is such that we cannot do animal surgery. So we developed our own the advanced course called decision making in major trauma, the theory part, and hopefully we are very soon we are going to incorporate cadaveric dissection into this. Protocols and guidelines are in place, but I feel that most of the time they are not being adhered to. And that may be a part of the reason, maybe that the supervision or critical appraisal, and that may be the reason. Rehabilitation. Now, that is, I think, the subject which people started being interested only in recently. And we have about 3 centers look after rehabilitation part, not only spinal cord injuries, but also the other the rehabilitation after other injuries as well. Now, recently we started developing a center for the halfway home after for the paraplegics who have getting a lot of problems getting being cared at home, and it's very difficult situation the paraplegics having been cared at home. Occupation health being looked after by part of the Ministry of Health, because we have a lot of workplace injuries. Compensation and rehabilitation has been a problem. And we are very poor in data collection. And I must add that actually we don't have a trauma registry. And although we are working on it, and I feel that one day we need to have trauma registry, because the amount of the trauma we have, we need some sort of regulation on this, and to make essential progress with our care. And injury surveillance being started, which collect only a small amount of data, And this was launched by the Ministry of Health for the last 2 years. And hopefully that will give some information for our, improvement in various aspects in the trauma care in future. Now, morbidity mortality, that is part of the trauma quality improvement. I firmly believe that morbidity mortality meetings can give a lot of impact, because most of you are aware that we have a very good maternal mortality rate. How that is being achieved is that the very tedious appraisal and the criticism of the maternal mortality done over a period. And similarly, I have a feeling that morbidity mortality can and give rise to actually better outcome in the time to come. So we are working on this actually to encourage the surgeons in the peripheries to have a morbidity mortality. Now, in certain places already people have started doing morbidity mortality and for the trauma, but most of the time those morbidity mortality incorporated into general surgical morbidity and mortality. So encouraging the surgeons to do this along with the other aspects of regulation and like preventable death penalty review, and combining with that, probably we will be able to have a better outcome. I keep, and hopefully that we will be able to improve the outcome as well. Now, disaster management. We are full of disasters, and we have so many natural disasters, and so all the 30 years of war we ended in 2009 was another disaster. But even that, after that, we have so many natural disasters, very common. And there is a unit in the Ministry of Health and who is looking after and working with what is called, there is a special ministry called Disaster Management Ministry, and they are working in very close collaboration with the Ministry of Health. And we have started the postgraduate training and giving a diploma to the students, nearly about 15 to 20 students per year. They have a 1-year course, and they study about disasters, and they have been posted to various peripheral stations to help with the organizing drills and institutional planning and so on. Now, as a surgeon and the College of Surgeons of Sri Lanka, which is a professional body supporting the trauma care in this country, and to a great extent. And we have, the college has a 50 years of existence. And our main areas of contribution is that specialty and all the surgical specialties, to look after all the specialties, and training and the welfare of the surgeons, and to advise ministry and services and future developments. So this year we have a special year because it's 50 years, and we have started the committee on trauma and given various subcommittees to look after each and every the aspect of trauma care, and to see whether we can improve in close collaboration with the Ministry of Health. Ministry of Health, the main body which looks after trauma care is a non-communicable disease NCD department of the Ministry of Health, which has been the focal point. And unfortunately, their burden of work is not only trauma, but also the other aspects of diseases, non-communicable diseases. So they have a greater involvement, and but they do involve with prevention. They do involve with injury surveillance and so on. So in summary, we have a lot of gaps. To fill the gaps, we have a lot of problems, and financial is one of the things. And strengthening training at the college is doing quite well, and is important, and we'll continue to strengthen the training component. And we need a more established quality improvement program. There is no doubt about that, and which should lead to a trauma registry, which we are trying to do that. And prevention is not at very good as it stands now. And I think the country should look after prevention as well, because the number of injuries which we are getting and is enormous, and I don't think it will have a very good effect on our society. And thank you so much for listening, and I hope that it gives just a glimpse of the trauma system in Sri Lanka.